questions, I'll post it in the Zoom chat room and everybody can see, or I can send you on WhatsApp, whichever way you want.
Okay, but I can see them on my screen because I'm gonna
Yeah,
note.
Zoom chat is the best way to deal with it.
Yeah,
I
so I'll
guess,
send on Zoom chat.
that's what I was thinking. Lovely.
Sure.
So just one thing before we start, Dr. Sanjay, he lives in Ahmedabad, okay?
Yes.
Yes, and Shirish, he lives in Pune, huh?
Pune, yeah.
Yeah.
Pune, yeah. Bahut acha, bahut badhiya. Okay, that's good.
Okay. So we are just connected online and start the proceedings.
Okay, good.
Good morning, Dr. Sanjay.
Good morning.
Haven't met yet, so.
Yes, indeed.
So welcome to this first Indo-Brazil collaboration webinar, and good morning to everybody in Brazil and good afternoon to everybody in India. We are here together to see this webinar on biology of rotator cuff healing and how to improve it. This is a disclaimer from the Author TV. We'd like to thank all our faculty for sharing their knowledge and expertise, especially in this challenging times. We wish all our audience a healthy and safe day ahead, and we hope these webinars add value to your time. These webinars are dependent on a lot of technology and internet speed, which might be unstable at times. So please bear with us for any issues of technology. So thanks for attending this webinar again. Over to you, Dr. Sergio.
So can I speak?
Yes, sir.
Okay, my friends. So it's a pleasure to have all of you here. I'm Dr. Sergio Ravinsky, shoulder and elbow surgeon from Brazil, from Shoulder Planet. Shoulder Planet is my international personal project in shoulder and elbow international medicine and surgical education. It's a pleasure to be here. This is one of the biggest achievements I have ever done with my project, and I am very thankful for Ortho TV for giving us this wonderful opportunity, which is something very special to me. None of them would have happened without the tremendous help of two special people, Dr. Ashok Shia, he doesn't need any introductions, nor Dr. Neeraj, who have been doing a tremendous, nice work for all of us, with not only with Ortho TV, but with all of these webinars, as Dr. Ashok has told in these difficult times that we are all passing through. We have today here a constellation of big stars, and I am very happy to have them all. So first of all, I would like to introduce to all of you guys my good friend, Dr. Ildeu. Dr. Ildeu Almeida is a very good friend of mine. He's not only my colleague, I consider him my friend, my good friend. He was the president of our Brazilian Shoulder and Elbow Society in 2019. And so he's the ex-president of the Brazilian Shoulder and Elbow Society, and still, besides, he was one of the organizers of the International Shoulder and Elbow Congress last year in 2019. So it's an honor to have him here. He lives in a city which is called Belo Horizonte, which is 500 kilometers from São Paulo. It's a very big city. And he's not only a wonderful surgeon, but a very good academicist. So it's a pleasure to have him here, and a big honor. Still, we have here my good friend, Dr. Shirish from Pune, stalwart from the Indian shoulder scenario. Everybody knows him. And still, Dr. Sanjay Trivedi from the city of Ahmedabad. One thing that I haven't mentioned is just that Dr. Ildeu, it's not only a shoulder and elbow guy for more than 25 years, I guess, something like that. But he spent 2 years when he started his shoulder practice a long time ago with Dr. Angus Wallace, which is one of the biggest shoulder guys in planet Earth. Nowadays, is the biggest shoulder guy in UK. And he spent 2 years with him, living in Edinburgh, in UK.
Nottingham.
Excuse me?
Nottingham.
In Nottingham, I'm sorry. So he has a very big, I would say, experience, not only in Brazil, but also abroad. So this is his introduction. So now this is what we are gonna follow with all of the help of Dr. Ashok and Dr. Neeraj. We will have now, so this is a meeting, a very nice meeting about the biology of rotator cuff healing, which we have been paying attention to a lot in the last years. A lot of attention has been given in the last 20 years about the biomechanics with double row, and a lot of new sutures and suture techniques, but biology is very important too. And we have been seeing a lot of papers about it. Last week, Dr. Ildeu organized a lovely event here in Brazil about biology of the cuff healing, and we are continuing this. I'm very happy about that. So this is the sequence. Dr. Ildeu is presenting a lecture about 20-25 minutes. He has all of the time he wishes, of course, about a lot of aspects of the biology of the rotator cuff healing and how to improve it. And also Dr. Shirish is gonna show a lot of tips with all of his experience. So we are about to have in a sequence, I guess, 40 or 4,500 of beautiful explanations. And then I hope we have a lot of time to talk. So I'm very happy to be here. It's an honor. It's a very happy moment in my life. And Dr. Ildeu, it's not only a pleasure to have you here, but now the microphone is all yours.
Thank you very much for the invitation. It's a great honor to be here with you. And I'm going to talk a little bit about the healing process of rotator cuff after the repair. And now I'm going to share my presentation. Thank you. Okay, it's all right?
Yeah, okay.
Yes.
Yeah.
Just a second, please. So I'm going to talk a little bit about the healing process regarding the rotator cuff repair. I work at 3 different hospitals in Brazil, Felício Roxo, Vera Cruz, and Horizonte. And this is the team that works with me. I have nothing to declare regarding the conflict of interest. I work as a consultant for Johnson & Johnson, but mainly for arthroplasties, shoulder arthroplasties. And I have elbow arthroplasty prosthesis, a Brazilian elbow prosthesis being developed. And yeah, last year, we have published a book about shoulder and elbow fractures here in Brazil. Well, when we talk about the healing processes, we have to take in consideration the local and the systemic factors, the pre and the post-op aspects. Specifically about the systemic factors, we have to take in consideration alcohol, obesity, smoking, cholesterol, diabetes, hypertension, immunobiological aspects, genetic, and age. When we talk about alcohol, you know that we have more massive tears. And the long-term alcohol intake is a very significant risk factor for occurrence and severity of the rotator cuff tear in men and in women as well. So the obesity increases the occurrence and the severity of the rotator cuff tear. And it's very well established that smoking is a great problem. And nicotine reduces this MMP9 expression in tenocytes. What is MMP9? It's an enzyme that involved in the extracellular matrix degradation. So the elasticity modulus of the tendon is changed after years of smoking. So there is no point in stop smoking before the surgery because the damage is already done, okay? And the risk factor for tearing propagation is well established by A.G. Itoy. Cholesterol does the same in the elasticity modulus of the tendon. And diabetes is something that we have to pay attention. In the past, we didn't look for about these aspects. We just indicate the operation and perform it. Now we know that we need to control the glycemic after the operation. Otherwise, the healing process will be a problem, okay? So hypertension increases 2 times the chance of large tears and 4 times the chance of massive tears. And this is an aspect that we can't control, these immunobiological factors. We know that this participates in the mechanism of fatty degeneration. So some patients have a tendency of developing fatty degeneration more than others. And unfortunately, we can't control that. Age is a problem as well. If we understand that the orangutangus at the age of 40 in the jungle is an old animal and has its rotator cuff degenerated, and now we are achieving 100 years, and our DNA is 97% identical to it. So we are going to have rotator cuff tear in between 40 to 100 years. So what can we do biologically to improve tendon quality and try to avoid this problem? So that's the next lecture, okay? And Fukuda has defined 5 different parts of the tendons. And he showed us that in a young pattern, a very well organized tendon. But when we achieve middle age, this tendon is swollen, homogeneous, so we have a degeneration already in the middle age. So these systemic factors are very difficult to control, but some local factors we can try to control. So we have to talk about tear size, muscle, tendon, bone quality, and bone morphology. Regarding tear size, we have to analyze it in both plans, coronal and sagittal. And we use Pat's classification and Caulfield-Bateman classification. And we understand if we are going to treat a small tear, we have a chance of 94% of healing. But if we are going to treat a big or a massive tear, the literature shows us that the chance of failure is as high as 97%. This number, 2.2 centimeter, is very important to remember. When we consider the tear in a sagittal plane, if you have a tear greater than 2.2 centimeters, you are going to have only 49% of healing. But if the tear is less than 2 centimeters, you are going to have 72% of healing. So when the tear is greater than 2 centimeters, it is always involving this infraspinatus. So this is something that we have to remember when we have an MRI in front of us. Regarding the retraction, the tendon retraction is not always due to the muscle that pulls it. It's due to the tendon to bone reminiscent, because some tears are in the middle of the tendon. They are not only avulsions. So in this case, the tendon is short. And then when we are going to repair it, if you repair it in the proper footprint, you are going to be over tension. So in these situations, it's better to repair it a little bit medially. I know that Dr. Rowiński likes to do these repairs a little bit medially. And this is a reason for that, to restore the proper tension. The tendon resorption occurs as well in the board of this because of the necrosis. So this is a problem that we have to consider during operation. If we have a retraction greater than 2 centimeters, we are going to have only 47% of healing. And if it's less than 2 centimeters, it's 76%, so it's higher. So we have to talk to our patients and explain them the chance of success of our procedures. Regarding the coronal plan, well, we pay attention during the MRI about muscle and about tendons, but we have to pay attention about musculotendinous junction. This concept we sometimes forget. And if we have the musculotendinous junction lateral to the glenoid, we are going to have a great chance of healing. But if it's medial to the glenoid, you have a high chance of failure. So that's another criteria to be used. Well, but muscle atrophy and fatty degeneration is very used for a long time now. Then we use the Guttelier classification, and if we have type 1 or type 2, we have a 75% chance of healing. But for types 3 or 4, we have only 41% of healing. And talking about muscle atrophy, you have to calculate the muscle occupation in the supraspinatus fossa. If we have less than 43% of muscle occupation, we will have a high rate of retear. So we have lots of criteria to use to understand the chance of success of our procedures. Well, tendon quality. When we talk about tendon quality, we have to pay attention about delamination, because delamination is related to prognosis, is related to chronicity, and the tendon is thinner than before. So when we have a look at the tendon during arthroscopy, we try to understand the quality of the tendon. Is it reliable? Well, this paper shows us that there is no correlation between macroscopic and microscopic findings or arthroscopic findings related to the tendon healing. So we simply can't predict if our tendon is going to heal properly based on our arthroscopy. And how to understand, how to identify delamination doing an arthroscopy. The majority of the surgeons do not change from the posterior portal to the lateral portal. And the adequate way to see, to identify delamination is using the lateral portal. It's a gold standard. So we need to change our practice. And before doing the repair, we have to change the arthroscope from the posterior portal to the lateral portal, and then go back to the posterior portal and start doing the procedure, okay? This paper analyzed 1,043 patients, and they said that there is delamination is not an independent factor. It might be related to other factors like osteoporosis, chronicity, tendon retraction as well. And can we predict bone healing based on bone morphology? This is something that I understand that we can do using the critical shoulder angle. The critical shoulder angle is the third image on the right, okay? If you calculate the critical shoulder angle, and if it's greater than 38 degrees, it means that you can predict, you can tell to the patient if the patient does not have a rotator cuff tear, that the chance of having a rotator cuff tear in the future is greater than if the critical shoulder angle is less than 38 degrees. So if you have a critical shoulder angle of 32 degrees, for example, the chance is of developing arthritis, not rotator cuff tear. And it's related to cuff healing. If you have a greater critical shoulder angle above 38 degrees, you have less chance of cuff healing. So what we can do during the procedure, trying to avoid this this impact on healing process, you can do a lateral acromioplasty. So as described by Christian Gerber, trying to avoid impingement after the operation. Bone quality is related to complications. So if you have a chronic tear, you might have a greater chance of anchor pullout. So you have to talk to the patient or to change our technique, increasing the strength, the bone strength. Some guys, they use methyl methacrylate, or some guys change from anchors to transosseous suture. Well, this is an interesting paper, and they tried to create an index for cuff healing. And they used some criteria as age, size of the tear, retraction of the tendon, Guttalier classification, bone quality, and work activity. So you have 15 points. And if you have less than 4 points, you have a great chance of healing. But if you have more than 5 points, you have a great chance of complications. We know, based on what we have spoken before, that we have lots of other criteria to take in consideration. But this index is established and is something that we can use it. Now, we have to talk a bit about preoperative aspects. Perioperative aspects. So we're going to talk a little bit about techniques, but I'm not going to talk about the biology of it, because this is the next presentation. To choose the technique, we have to dominate the principles. So we have lots of options. You can do transosseous suture arthroscopically or open. You can do suture bridge, double or single row, but you need to know the basic concepts. And the basic concepts, they were established since 1994 by Christian Gerber to 2016 by Kim. And they took in consideration rigidity, strength, stability, tension, gap, contact pressure. And we are going to talk a little bit about these techniques. So what kind of surgical strategies do we have to reconstruct the rotator cuff tear? So we have various construct configurations. And we have many factors that contribute to structural integrity of the repair. These include repaired rotator cuff tendon footprint motion. So what kind of mobility we have after our repair. Increased tendon footprint contact area pressure. So what kind of procedure we are doing and what kind of pressure we have between the tendon to the bone. And increasing tissue quality tendon to bone. In these cases, we can use biological issues to increase the bone quality and the tendon quality. Well, let's talk about single row, which is the most used procedure in the world. It's less expensive, it's less demanding, but we have just 67% of covering the footprint using a single row. But the functional results are not bad. They are similar to double row. So that's the procedure I do in the majority of the cases. In some specific cases, it's better to do a double row. In the double row technique, you increase the footprint, the footprint area covered, but you not increase that much the contact between the tendon and the bone. So to do that, you can do a suture bridge technique. So the pressure between the contact area between the tendon and the bone is greater, but it might compromise vascularity. So you can have all the best things from one procedure. Yeah? Well, if I'm going to have my rotator cuff repaired, I would prefer to have this right X-ray after the operation than the left one. So transosseous suture is an option. And Alex Castagna has described it this procedure on his book, using these guides, LCA guides or shoulder guides, to do a transosseo suture. Well, after doing the procedure, we have to pay attention about some aspects. Otherwise, we are going to have failure. And I just use non-steroid anti-inflammatory drugs in the first 2 or 3 days to control pain, because I like to do a multimodal control of the pain. If we use non-steroid anti-inflammatory drugs for more than 3-4 days, we are going to have a bad effect on the healing process. Regarding rehabilitation, we can choose from an early passive motion protocol to a delayed range of motion protocol. And here, I have some doubts, because some people say if you perform a delayed protocol, we are going to have more stiffness. I'm not sure about that. I think that the shoulder stiffness is more related to other aspects of the patient, much more than the time that you use for immobilization. So sometimes we do an early passive motion protocol and the patient becomes stiff anyway. So I think the sensibility, the pain control, the psychological aspects of the patient, and much other, the reaction, the biological response from the body to the procedure is another aspect to be considered as well. But this paper talk a lot about that stiffness is a complication that you can treat, but non-healing is a failure, and it's a major problem. So that's something for us to discuss, okay? Well, immobilization. Most of the surgeons tell to the patients to keep the sling for 5 to 6 weeks after the procedure. But the literature tells us that if we use for 4 weeks is okay. There is no support for using more than 4 weeks. But after the procedure, if the patient is an old patient, the bone quality is poor, the tendon is very thin, we try to use the sling for more than 4 weeks in the majority of the cases. And the abduction sling is another thing that it might be okay for reducing pain, but there is no support for using abduction sling regarding the healing process. It's not proven that it improves the healing process. So that's something to be discussed as well. Well, I'm very open to the questions in the end of the presentations, and thank you very much for the opportunity.
Hello.
Yes.
So my friend, Yudeo, are you listening to me?
Yes, very much indeed.
Okay, good. So see, I'm very happy because you mentioned a lot of stuff that we can discuss, a lot of things. This is going to be not only good for us, but very good for the audience, which doesn't have so much, I would say, experience with all of these things. But I noted a lot of things that we can discuss. It's going to be very nice. And now, Dr. Shirish is going to talk about his experience with enhancing the biology. He has a lot of experience, of course. So let's hear it, and then we can start a nice discussion, not only between us, but obviously with the audience. So Shirish, the screen is all yours.
Sergio, can you hear me well?
Yes, very good.
First of all, I would like to thank my friend Sergio from Brazil for involving me in this first Indo-Brazil webinar. I'm very happy. And also Ortho TV team, Dr. Ashok and Neera on the Ortho TV. So I think whatever Dr. Udo has already mentioned, whatever I'm going to talk is in continuity with what we have discussed. So let me start with my presentation. So enhancing biology of arthroscopic cuff repair. How do I do it? So as we know, rotator cuff disease is prevalent in the aging population and is the most common cause of shoulder pain and disability. What are the indications for cuff repair? By and large, a full thickness tear with severe pain and disability, weak abduction, which is not responding to conservative treatment, and the person who is active, irrespective of his age, I would take into consideration the physiological age. I think he becomes a suitable candidate for cuff repair after adequate counseling. The surgical goal of cuff repair is to create a low tension, stable repair construct, which is strong enough to sustain till biology takes over. Now I'm going to show you a video. This is I would say a large rotator cuff tear, a U shape involving supra and infraspinatus. You can see glenoid and retractability, quite repairable. The footprint is almost covered fully. Now in second video, you can see I have created a nice footprint. I have done a microfracture to create more growth factors at the footprint for better biology and healing. And then my anchor construct with double row repair with transosseous equivalent. This is the final picture. Okay. Now my question is if I ask you whether this repair is going to heal and give a good functional outcome, will you be able to answer? I think it is very difficult because it is not only the arthroscopic procedure, but there are so many factors which are playing role and which will effectively give a better biological healing at the rotator cuff. And in first lecture, we have listened, there are so many patient factors, local factors, tear pattern factors. So one by one, I'm going to go through that. So if at all, if this repair heals, we need to ask ourselves why this has healed. And if it does not heal, we have to ask ourselves why it has not healed. I think we always see macroscopically the rotator cuff, and we are very proud that we repair them anatomically as far as possible. But at the same time, as a surgeon, we should or need to know some basic science. First, we should know what is microscopic anatomy of tendon and the tendon bone junction. What happens at cellular level when tendon tears? What are phases of tendon biological healing? What are factors which affect biological healing, which stimulate or inhibits biological healing? And last, which is very clinically relevant, is how to improve biology. So what option do we have at our hands so that we can effectively improve the biology? Now let us start with the histology of the tendon. So as we all know, the extracellular matrix of a tendon, 85% is collagen. Rest is non-collagen protein, which includes proteoglycans and GAGs. It's very important to understand it is primarily a type 1 collagen. 95% is type 1 collagen. And the cells are called tenocytes or fibroblasts. And there are certain cells which are around the tendon, peritendon sheath cell. So both have important role in laying down the collagen. Now, tendon bone junction. We have to understand the different parts of muscle, tendon, and how it inserts onto the bone. It is very relevant when you do arthroscopic cuff repair. Now we know myotendinous junction is the weakest link, but we have to take a look how it inserts. So we have a tendon, then we have a fibrocartilage, then a calcified fibrocartilage, and then the bone. So this transition is very important. And when we repair tendon, we hope that this sort of architecture will be reproduced, or it will eventually get remodeled to this sort of anatomy to give the best possible result near anatomy. Now, what are phases of rotator cuff healing? I think this is very relevant because it is going to dictate not only your technique, but also your post-operative rehab protocol and the restriction of activity and how to go about increasing activity and eventually the strengthening. So the first step is inflammatory, which is there for about 5 to 7 days. Then is the stage of repair, which is roughly up to 3 months. And the last stage is stage of remodeling, where you gain the maximal tensile strength, which happens roughly about 3 months, and it goes on for few weeks more. So now it is very important to understand the first is the inflammation, second is the repair, where a type 3 collagen is being produced, which is not the right collagen for the tendon. But remodeling is a stage where this type 3 collagen is going to get converted into type 1 by a cellular cascade, which is very important. So if you are able to achieve a type 1 collagen, a nicely healed tendon at the end, then that's going to give you the best outcome, best functional outcome and strength. So I would like to go through few steps because I thought it is very important as a surgeon to understand what is happening. So if there is the acute rotator cuff tear, then what happens at the cellular level? So in inflammatory phase, which is roughly first 1 week, the injured tissue is going to release the cytokines. These cytokines causes neutrophil attraction and mobilization. These neutrophils, they release interleukin 1b and tumor necrosis factor alpha, which are the primary inflammatory cytokines. And they activate nuclear factor kappa B, which leads to the process of apoptosis in musculotendinous units. So this happens precisely if we leave that tear without repair, or if we just ignore it, leave it, then this apoptosis is going to lead to further loss, further tissue damage, muscle atrophy, and eventually fat infiltration. But if we repair it, or if it is a partial tear which has got potential to heal, then probably it will go to the second stage, which is of stage of repair, where musculotendinous units now will start anti-inflammatory effect, and they will start regenerative process where they will create pro-fibrotic factors from extracellular matrix, and now multiple growth factors like transforming growth factors, IGF, PGDF, GDF. These are all platelet growth derived factors, many of them, and they act synergistically. They clear the dead tissue and stimulate regeneration. And now in later part of this inflammation and start of the repair, macrophages, they come in action, and angiogenesis and fibroblastic activity starts, which primarily secretes collagen type 3. So we have to understand from the basic science that the reformation of normal tendon bone attachment takes at least 24 weeks based on histological analysis. So the strength of rotator tendon repair is very low in animal model when measured in first 6 weeks. And I think it will corroborate in human model as well. So now we have to understand, coming back to the same question, that tendon which we have repaired, is it going to heal? Is it going to repair? So we have to look into the literature. So if you see, there's so much literature telling us about overall healing rates, and these healing rates, as rightly mentioned earlier, they vary from 60 to 90%, and for large tear, even they have reported healing rate less than 10% also. So we have to understand most of our repairs are not actually getting healed, which range from 10 to 30% and maybe even more. So it is very clear that the healing is very less than we thought previously. And then it ignited controversy, whether open arthroscopic, whether a single row, double row, whether a suture configuration, whether type of anchor, whether the post-op rehab protocol, which is playing an important role and leading to less biology and more repair rates. So does healing really matter? That is another question. Whatever you have repaired, if it heals well, then it has been proven in literature, a healed intact rotator cuff is going to give you far better functional and clinical outcome and strength as compared to the one which is partly healed or not at all healed. So the problem here, I think, is the poor biological healing. So we have to look into the factors. So I would go quickly through this because most of these factors have been already covered. So I would like to divide them as patient factors, surgeon factors, and of course the rehab protocol, and then miscellaneous factors. So in patient factors, so these are all patient factors which tells me before surgery that this candidate is a candidate where there is a poor biology. So increased age, uncontrolled diabetic, uncontrolled hypercholesterolemia, use of recurrent NSAID for a pretty long time, the smoker, osteoporotic, vitamin D deficient patient. These are the patients who are poor biology patient for me. So I'm going to be little careful and counsel them and try to correct the correctable factors, whatever possible, to give a better biology. Now, cuff tear pattern. So acute versus chronic. It has been proven in literature that if you repair them early, the healing rates are far superior. Because as you have seen the process of biological healing, if you intervene at a repair stage, then it is going to complement the healing process by giving anatomically repaired tendon. Again, the size, grade of retraction, tendon loss, fatty atrophy, everything plays a very important role, already discussed. So I would skip this references because they have been already covered, only to mention that if the age advances, the percentage of cuff healing is going to go down. And if the tear size goes up, again, the healing rates are going to drop. This is the bottom line. Osteoporosis, again, is an independent risk factor. And as correctly mentioned in earlier lecture, if there is a back out of the suture anchor before the cuff biologically heals well, there is going to be high rate of failure leading to bad result. So we have to be very careful while choosing our patient. If we have osteoporotic patient, then you should be ready with alternative option of suture anchor or alternative suture repair techniques. So just similar to the scoring system, what Dr. Ido mentioned, I would classify my cuff tear scenario in 3 groups: favorable, unfavorable, and hopeless group. So favorable is a younger patient, less than 65, smaller tear, typically traumatic ones who present early, minimally retracted with good muscle bulk, Gottalier 1 or max 2. These are good biology, good result. Unfavorable, age more than 65, large tears, grade 2 retraction, tendon loss, and grade 3 or 4, grade 3, Gottalier, poor biology relatively. And this is the last group where I would not repair the cuff tear. Rather, I would look for other options. If patient is more than 70 with grade 4 retraction, osteoporotic bone, I may think in terms of reverse shoulder orthoplasty or just leave them alone with the good rehab. Now, surgical technique, does it make difference in the healing? I think yes. If fixation is unable to handle the post-op loads, biology just cannot compensate. So we have to make the best environment, best situation for the cuff to heal and the cuff to be biomechanically strong enough till the biological bonds develop between the tendon and the bone. So again, surgeon factors, the level of expertise, ability to understand the tear pattern, mobilization techniques, repair techniques, properly done single row and a properly done double row, and most importantly, the augmentation of biology. I think each and every point in this slide is for better biology. You can't say the biology is something different, which is like a holy grail, which I'm going to add later. No, it starts from the selection of patient and step by step with your every surgical step. So I would summarize, if you do your mechanical job correctly, then you are trying to improve the biology. So you have a correct suture strength, multiple suture, correct suture configuration, adequate number of sutures anchor, right technique, nicely prepare bone footprint, do subacromial decompression, microfracture. You can do this irrespective of whether you're doing single row or double row, because some tears will dictate you to do a single row repair. So never mind, you can do whatever technique you want to follow, but follow this and you will give a very good mechanical construct leading to best biology possible. We all know there are a lot of biomechanical data on cadaveric study, lab study, that double row repair gives a better fixation, better contact between tendon and bone, increased load to failure, less gap formation, and increased cyclic load to failure. So I think that has led to a better initial strength fixation and better results with newer double row repair techniques. So to summarize, I think it appears that there is definitely a structural benefit of structural healing when you do a double row fixation as opposed to single row fixation. This is more applicable for tears which are more than 3 centimeters. Now we are talking about the healing. The functional outcome may be not so much different, but if you see the healing patterns, I think with double row, it is definitely better. If you're doing a medialized low tension single row repair, don't forget to open up the channels on the lateral part of the footprint, which has been popularized by Professor Schneider, which is, he calls it a crimson duvet effect, where he gives a bone marrow vents to create more growth factors, super clot formation, leading to better biological healing. Now coming to the post-op rehab protocol, I think this has been already covered. So there is a lot of conflicting evidence, early versus delayed. So recent JBJS review concludes that there is no difference in retear even if you start early mobilization. But it is very important to understand, you can't apply same rules for all patients. It has to be individualized decision. When you are dealing with large and massive cuff tears, it is better to give time for biology to take place and better healing than be in a hurry to get early range of movement. So go slow if it is a large or massive tear. Now there are a lot of options in market available to augment the biology. So we would divide them into 3 types: teno-inductive, teno-conductive, and teno-productive. So let us go one by one. So what is teno-conductive? So these are nothing but scaffolds. So there are scaffolds available commercially. There are 3 types: xenografts made from porcine, a dermal or submucosal patches. In India, very few are available, and exorbitant cost is the problem of using them. Then allografts, there are certain graft jackets, human dermal patches, and synthetic grafts, so Gore-Tex patches. So these are scaffolds which will definitely help you, and they have a limited role in large retracted cuff tears to augment the biology. Now second group is tenoproductive. Now this is a whole orthobiologics which is coming up. Still we don't have a very good evidence to use them, but we definitely know that they are proving beneficial day by day. So there are 2 types of cells: adult and embryonic stem cells. The adult stem cells are primarily multipotent mesenchymal stem cells. You can harvest them from bone marrow or adipose tissue. And there are placenta-derived pluripotent stem cells. So they have capacity to transform themselves to any type of tissue. So here, if you use these mesenchymal stem cells and give them the right environment, then they probably will differentiate into a rotator cuff tissue, giving a better biology and a better healing. And the last is the teno-inductive. So I think these are nothing but the all growth factors, cytokines. So what we studied or discussed during the repair phase, these are all cytokines. They are produced by body as a response to create repair. But if they're available at your hand, then probably you can add them during repair and hope to have a better biology, because they play important role in migration, proliferation, and differentiation. And a single growth factor is not going to help you, but multiple growth factors, they act synergistically and give you best results. So there are transforming growth factors, bone morphogenic protein 12. So there are plenty of them available. Now, the last group which I'm going to discuss is the platelet-rich plasma. The best way to get autologous growth factors in a better concentration is the platelet-rich plasma. So platelet can give you a lot of growth factors: TGFB, PDGF, VEGF, EGF, IGF. See, you can go to the long form, insulin growth factors, vascular endothelial growth factors, plenty of them. So a simple technique of centrifuging them and separating plasma, platelet, leukocyte, and RBC can help you to get a concentrate of these growth factors, which has got a small put them at right timing, then probably they are going to help you in healing. So there are 4 types of PRP available in the market. So there is again debate going on leukocyte rich and leukocyte poor, then plasma and fibrin, pure PRP. So it's still debatable, but there is some benefit proven in literature. A lot of animal studies and few trials on human subjects also claim good results. So let us go one by one. So you have 2 types of PRP. One is leukocyte rich and one is leukocyte poor. Leukocyte rich is where you want to induce inflammation, like where you want to do like lateral epicondylitis, you can use leukocyte rich. While poor is something which you would like to use for cuff repair, where you want to primarily give regeneration. And PRF is the platelet-rich fibrin. If you add calcium and if you activate the platelet, then eventually it is going to form a thrombin and leading to a platelet-rich fibrin matrix. So the advantage is it forms like a matrix membrane. So you can put it wherever you want, like a patch. So it has been used effectively in rotator cuff repairs and meniscal repair. So instead of injecting, you can actually place it and incorporate in sutures to give a better biological augmentation. So this is the current recommendation for use of platelet-rich plasma. But we know for specifically cuff repair, there is lack of data. Still, it is, I would say, experimental. Now, the recommendation for biologic therapy in rotator cuff is PRP has not been shown to improve healing rates or reducing retear rate, but they have said it definitely has got some adjuvant role in reduction of pain, and there has been some benefit in small to medium sized tear in high risk patient where you know that biology is poor. And biological patches augments with growth factors implanted on them. They have definitely some role as dermal patches in large and massive rotator cuffs. So this is what current guideline in 2018 and 19 tells us. So just to summarize biological augmentation strategies. So at one hand, you have scaffolds. At one hand, you have cells like bone marrow cell, mesenchymal cell, and then you have bioactive molecules like platelet derived growth factors. So now you would ask me whether I use them in my practice. Unfortunately, I use them in few of my patients, but still there is no current evidence and it adds a lot of cost. But what I do is I utilize the local anatomy, local procedure to give this growth factors. So it has been proven that if you do acromioplasty, then it gives you a lot of growth factors like platelet derived growth factors and plenty of them And there is a study where Pietro Randelli did, and he took 2 cc of fluid from subacromial space after doing acromioplasty and compared with another group where acromioplasty was not done, and they found the concentration of growth factors was too high, like a PRP, in patient where you have done a thorough acromioplasty. So I make it a point that I may not do a formal acromioplasty for all of my patients, but majority of them, I do a thorough tuberoplasty on greater tuberosity side and a thorough judicious acromioplasty on the acromial side to create these growth factors which help in biological healing of my patients. So in summary, I would say to optimize biology, it will start right from selecting right cases, do early repair, if possible, do double row repair, augment your repair with microfracture, do judicious acromioplasty, which is going to give you a free local PRP, ask patient to stop smoking at least in perioperative period. It will to some extent help you in biological healing. Don't use non-steroidal anti-inflammatory medication for a very long time. You can use these medication as and when required. We solely rely on induscalin blocks and patches in immediate post-op period. And of course, you have to have a individualized physio protocol to prevent re-tear because of too much aggressive physiotherapy in early post-operative period. Thank you. Thank you for your patient listening.
Hello.
Yes, Sajid.
Okay. So see, folks, that was a lovely presentation showing a lot of things. I made a lot of notes. We could be discussing this for the whole day, but I think we can do a nice discussion now. I have a lot of things to mention, and obviously everybody can say whatever they wish, but I think that we must pay a lot of, I would say, attention with the audience. We have beginners, not experienced surgeons, as all of us are. And Dr. Ashok was telling me about some basic things that people were asking. We have basically 3 questions. The PRP was already answered about by you, Shirish, but we can discuss. But there's 2 questions that I would like to start with. And the first one is very basic. I'm going to reply. And then a second one, I'm going to give my feelings, because as Dr. Ildeo mentioned, I have a good experience with that, as all of us, but I'm going to mention. And then I would like to know what you guys think about, and we can discuss this. So the first one is, there is a very basic question is about which are the MRI findings that can predict a worse respond, a worse outcome. So this is a very basic one, but I think we must mention to the audience, which is when the lesion is retracted or I would say medially to the glenoid, this is a very bad predictor sign, or as Dr. Ildeo has mentioned, after 2.5 or 3 centimeters, this is something that would lead to a worse outcome, in spite of the fact that I have a lot of experience with big tears, and I'm going to comment upon that in, as we discuss. And of course, the Goutallier classification, as all of us know, when you have more than 50%, that would, I would say, lead to a less, not to mandatorily a bad outcome, but to a less, we can less expect, I would say, a quite predictable good outcome. This is quite, I would say, mentioned in literature. But the second one is about the tension. So someone was asking, how do you manage to get attention free, and how do you decide it intraoperatively? So this is very easy to me, because I use it all of the time, as all of us, but I'm going to talk a little bit about this with medialization. What you must do is to do a lot of releases, and then to pick up the tendon and to pull it and to see how much does it cover the footprint. And as long as it doesn't cover, you don't have to fight with it, but rather than that, to achieve a tension-free repair, which is something that I decide, I would say, with my eyes, macroscopically. And if I have a doubt, I do the medialization of the footprint. So what I've been seeing over these years, and Snyder said, is that as long as you do a tension-free, and I decided with my eyes macroscopically, after some time, the scar will cover all of the footprint. And I have 4 cases in my life so far. I showed it to Dr. Ildeu 5 days ago, 6, in which when you do an MRI 1 year after the surgery, the footprint is covered. So as long as you do a tension-free, which you decide macroscopically without medialization, it will heal. So my decision is absolutely with my eyes, and after a lot of releases. And if I have a doubt, I don't spend a minute, I'm talking about big tears, of course, in medializing the footprint. So I would like to know you guys, if you think the same, and if not, how do you, I would say, interpret a tension-free repair intraoperatively? And this is very important for the audience. So now I open the mic. Dr. Ildeu, how do you manage to, would say, decide what is a tension-free or a repair with tension intraoperatively?
Yes, regarding tension, I think we have to talk a little bit about a basic concept, which is the rotator cuff cables. We have the anterior cable, which is the superior border of subscap and the coracohumeral ligament. And we have the posterior cable, which is a little bit posterior inferior. So it's the anterior cable and the posterior cable, which is in between infraspinatus and teres minor. So we have some balance. So we do not need to cover the humeral head completely in chronic and in massive tears. So if we have this balance achieved after the operation, so we might have improved the function and decrease the pain. So first of all, as I said, we need to put the arthroscope on the lateral portal, and we have to feel the elasticity of the tendon and the quality of the tendon, if it's a good quality or bad quality. It's not related to healing, but it's related to the tension and where you are going to put your stitches. This sometimes when you have an MRI with a massive tear after a small trauma, an old patient at home, so some tears are chronic ones and others are acute ones. So you have to pay attention not to try to repair the old and chronic tears, because the patient was very good with that tear.
And very adapted. And very adapted.
Adapted. So yes, you just have to reconstruct the acute one. So if possible, you do the chronic one, but there is no point in trying to put it over tension. So you have to feel the tension. It's something difficult to explain by using words. You have this is something that during your practice and with another surgeons, you will balance the tendons and see the proper place to put the stitches.
But just one thing. So you have the same feeling that I have, and I'm very happy with it. But see, this is something that I see case by case with my eyes. There is not, I would say, a receipt, a cake receipt. So I think that you do the same. It's a matter of feeling in every case. How much can you pull? And you say at some point, that's enough. That's the max I can pull it, and you can fix it, I would say, let me use the expression, in situ, and that's it. I guess that's exactly what you do, and it's a feeling, I would say, intra-op in every case, huh?
Yes, I think we have to pay attention about the release, the amount of release we perform, because during the posterior superior release, we have the suprascapular nerve. So I don't know how do you do the release, if you use the shaver for that, or if you use the bone
the periosteal
yes, yes,
the arthroscopic periosteal elevator.
is exactly. So I had at least 2 cases of suprascapular nerve damage doing a very big
Big test.
release. Big, yes. So the French guys, they say that some degeneration of the cuff is related to the retraction of the rotator cuff and compromising the suprascapular nerve. So doing a balance, you are going to decompress the suprascapular nerve and
Just
increase.
a second. This is, I want you to comment about, because many few people know in the audience, this is what Laurent Lafosse calls as the shoulder carpal tunnel syndrome.
Yes.
Yes. So, but what literature says is that when you pull down, I would say, when you fix the tendon, you would be releasing the nerve as a carpal tunnel syndrome. Lafosse does, he talks about it, but and I guess that you feel the same, huh?
Yes, there is something else I would like to add, which is the traumatic tears, because we say that the retraction is a poor prognosis aspect, but in the traumatic tears, if the patient is a very strong guy, sometimes you have a lot of retraction, but during the operation, you see that it's very easy to bring the tendon to the proper place. So you have to take it in consideration before the surgery.
Yeah, so see, you mentioned something that I really care about, and I'm gonna comment my way, and I would like to know how Shirish thinks about it, and Dr. Sanjay. You told me, how do I do releases, huh? So you see, so above the cuff, I go with electrocautery because there is much bleeding on the bursal side. So if you go with the shaver, it bleeds a lot, and you take a lot of time to stop the bleeding. So I do with electrocautery radio frequency device. I don't care about the nerve because the nerve is below the tendon, but I care too much about damaging the suprascapular nerve. So I go with the periosteal elevator, but no more than, I would say, 1 centimeter medial to the superior board of glenoid. And I have a lot of fear of damaging the suprascapular nerve. And so far, hopefully, I had not problems with that. But so I would like to ask Sanjay and Shirish, how do you do your releases and how much do you fear damaging the suprascapular nerve? This is a very important question that Dr. Ildeo has mentioned, and especially for beginners, they must understand that you cannot be very aggressive. You must go with care, especially regarding the suprascapular nerve when doing releases. Sanjay, what do you think about it? And then Shirish, please.
Yeah, Dr. Almeida and Shirish, excellent overview of the healing process and the factors affecting the healing for the rotator cuff. You haven't left anything untouched, but only one thing for the beginners we need to understand that today's keyword is low tension repair. And that is the buzzword in the today's 2020 era. So very aptly asked by one of our listeners that how to measure the tension. Now, before coming to that, when you enter into the subacromial space, or first when you look at the cuff without any bursectomy or anything, there would be a great deal of tension in the cuff when you try to catch and hold and try to bring it to the footprint. You need to understand the tear patterns also to access the tension into the cuff, and you need to grab from anterior cuff tissue and bring it to the footprint, to the posterior footprint. You need to catch hold of the central portion and try to bring it there. So once you are able to identify L or reverse L, seemingly high tension repairable cuff would become an extremely low tension repairable cuff. So that you need to understand. Secondly, once you've done that, you must assess the tension before the release and after the release, because there is going to be a huge difference in these two stages. So what I do typically, thoracohumeral ligament or anterior release is very important. I do that, and then I bring my attention to the spine of the scapula. And when I erase the bursa from the spine of the scapula without damaging any of the muscle fiber or tissue or nerve, I'm able to get a great deal of excursion of the cuff, laterally, because by bursa, it is attached there.
Yeah, just a second. I'm sorry to interrupt you, but just for the audience to understand that, as Burkhard said, the cuff, it doesn't come from medial to lateral, but from posteromedial to anterolateral. So what you have said is absolutely, I would say, I agree, because I see this all of the time. You doesn't pull especially the posterior part of the posterior superior cuff just lateral, but lateral anteriorly, because the cuff doesn't go from from medial to lateral, but from posteromedial to anterolateral. But still, Sanjay, how much do you fear damaging the suprascapular nerve when doing the releases? Because this question from Ildeo is a key point.
Right. So you got to be extremely cautious to not go beyond your spine of the scapula once you make it bare. You do not go medial to that, at least in the anterior, just anterior to the spine of the scapula. That is where you might end up with the trouble, and you don't need to release that part. Once you erase your bursa from the spine of the scapula, most of your release is achieved as far as the center portion of the cuff is concerned. And sometimes apparently U-shaped tear is a posterior tear, and you can bring it anteriorly and laterally very easily. To quantify the tension into the cuff tear, there has been papers quantifying the appropriate tension in the cuff repair. And if I can share my screen, I can just show you this paper, in which they have now this is the Korean paper. It is a retrospective study, and they have defined this tension. That what they did, they checked the integrity of cuff at the end of 24 months by MRI. So they defined that greater than 35 Newton tension is a too much tension. And this has been published in the Arthroscopy in November 2020. So this is a fairly recent. So 25 Newton is the cutoff tension limit. Less than that, you are good enough. More than that, it is bad for the cuff healing.
Yes, more than that, you will be in danger. That's exactly what I feel. That's a lovely explanation, but I would like Shirish to give his thoughts about it. Shirish.
Yeah, I think most of the points are covered, but while doing arthroscopy, what I would do typically is put a traction suture in the lateral edge of the torn cuff tendon. And after every release, I would check how much mobilization I have achieved. I don't want to overdo it. I don't want to underdo it. Second, when I do my cuff repairs, my arm is almost by side. I do it in lateral position. I release the vertical traction. So arm is almost by side so that it opens up subacromial space very well. So when arm is almost by side, maybe 10-50 degree of abduction. And if I do a low tension repair, which is very easy to get it to footprint, if there is a tendon loss, I don't try to pull it too much to cover the whole footprint.
Yes,
I take
yes.
into the consideration of the lost part of the tendon, and then I don't mind medializing it and repair it. That's how rough judgment of the tensioning I do it. And I agree. I release CH ligament anteriorly for sure to mobilize the anterior leaflet. Posteriorly, I don't do interval release between supra and infraspinatus because I think it's a conjoint tendon. I want to maintain the integrity. And I would use a blunt periosteum elevator, as you rightly said, so that there is no chance of damaging suprascapular now.
Yes, so this is something I would like to mention because there are, I would say, blunt instruments like the periosteal elevator, but some they are, I would say, more sharp, like an arthroscopic osteotome. And you shall not use it, of course, just blunt. But see, many questions they are coming. I would just mention that I don't do posterior interval slides and anterior interval slides. There is a question coming about it. I would just to look. I think we don't have to talk too much about it. So many things to discuss. But any of you guys like to do posterior or anterior interval slides? Because the answer is I don't do it. But Shirish doesn't do it. So
I don't do it as well. No.
Dr. Ildeo, do you have any concerns? Because I don't do it.
Yes,
So-
I would like to say something about the post-operative recover of strength. You might have some patients that do recover the abduction strength, but do not recover the external rotation ones. And we say that, that's because the infraspinatus is poor prognosis muscle. But I believe that some of these cases is that because we have damage the suprascapular part of the nerve that goes to the infraspinatus. So the problem is that we do not study this problem properly. We do not ask the
myography.
Yes, myography for these cases. So we simply do not have the diagnosis done. And I think that we should pay attention about these cases a little bit more.
Yeah, okay. So another thing that is coming, I think that we have a lot of things to discuss, but I want to give attention to the audience. The thing is, Dr. Ildeo talked about the critical shoulder angle, and some things are very clear in my mind, and some not, of course. So the thing is, what I learned with the critical shoulder angle is that, we should not only do an anteroinferior acromioplasty, but also a lateral acromioplasty. And I have been doing this for about 3 or 4 years. So far, so good, because I care a lot about not only the number of the critical shoulder angle, but the idea of downsloping, the downsloping of the acromion. According to that paper, Gerber said that the insertion of the deltoid is not only lateral, in the lateral border of the bone or acromion, but also superior. You don't have to detach the deltoid, but not detaching it, I pay a lot of attention to downsloping and to do a lateral acromioplasty and not only anterior. And also, as Shirish said, we have to think about the biological aspects, which is the blood coming from the acromioplasty. So my question is to all of you panelists, and this is a beautiful one. Do you care about lateral acromioplasty? I think this is good for beginners. And also, how much do you care about the critical shoulder angle? Because I know it, but I don't know what to do with it in my practice. So I think this is a good question. Ildeo, any concerns about how much the critical shoulder angle, I would say, have, and how can you apply it in your practice? Because I know it, but it doesn't change too much to me besides the idea of the lateral acromioplasty. How do you use it in your practice? I think this is a nice discussion, and I would like to listen to the other panelists.
I think we have changed the way of analyzing the acromion shape after and before the critical shoulder angle.
Okay.
We use it to use the Bigliani classification for 20 years. And now we know that the critical shoulder angle, I understand it's more important than the Bigliani classification, because the lateral aspect of the acromion regarding the position of the cuff is more important for the tears than the curve of anterior curve of it. Okay, so we know that when we do an anterior inferior acromioplasty, if you perform an MRI 1 year after, you are going to have the coracoacromial ligament intact again. So the problem is that the impingement is not anterior-inferior. In these cases of the critical shoulder angle is open, the impingement is lateral. So you have to individualize your acromioplasty. That's the question. And I'm extremely happy to hear from Dr. Pathak that the growth factors and the biological is increased by doing an acromioplasty, because I believed on that for many years, but I didn't have literature support to say that, and now I have. Thank you very much.
Oh, that's good. So Sanjay, how the critical shoulder angle has changed your practice, and what do you think about lateral acromioplasty? I absorbed that idea for many years. I'm happy with that. What do you think about that? And
thanks, Sergio, for this question. My thought process has been, slightly different about this. The effect of the acromion on the impingement acquired bursal type rotator cuff, and I have always thought whether it is the effect of the loss of biomechanics of the shoulder forward elevation and abduction because of the tear, or it is the effect of the acromion itself. There has been a lot of struggle in my mind to understand that clearly. The Bigliani classification considered this as a cause of the problem with the shoulder. Slowly, it became evident that it is been overplayed. And
somehow we don't know if this is a cause or a consequence.
Or effect, yeah.
And this is the old discussion. Dr. Ildeu, he was talking about that. The chicken and the egg, and the chicken and the egg. Who came first? But still,
so critical shoulder angle is a new kid around the block, reinventing the theory of Bigliani's lateral sloping acromion. I am just keeping an eye on it. I'm just noticing it, but I am not applied it into my management yet. I still continue doing only in anterolateral sloping acromion. In my outlet view, I have continued flattening that area. I am still not touching the lateral side of the acromion, and I'm waiting for solid evidence, high power study telling me that it reduces the retear rate. And then, I'm in kind of, I don't just catch on the early worms. I just try to let it play for a couple of years and see where it feels and then fall. I am kind of follower of that philosophy. Shirish, you?
Okay. Yeah, Shirish, what are your concerns about this discussion, this nice new idea, relatively new idea?
Yeah, so I think in 2017 we had Asian Congress in Mumbai, India, and Christian Gerber did a presentation, and it was something new, and it was quite exciting to learn about this new angle and everything. But I agree, I'm exactly in sync with Sanjay. I've started observing them, but I have not changed my surgical technique.
Okay. So different points of view, but that's part of the game. But there's a question that I'm gonna ask Shirish. It's coming from the audience about what is your experience with patches and scaffolds. Mine is none, and we were in International Congress of Shoulder and Elbow Surgery 7 months last year, which was organized also by UDEL. And there was a presentation about that, and someone from Canada, I guess, was telling that the results were very disappointing. The JAG graph and all of the other ones, because these scaffolds, they cannot reproduce biology for tendon ingrowth. So my perception is that they are quite frustrating, but I have absolutely no experience. Have you done some? Do you have any good results? And Dr. Yudeo and Sanjay, what are your thoughts about scaffolds?
So in my practice, I have never used them for two reasons. As I said, they are not available. The one which is available is porcine, and it is very costly. So there are some religious reasons where people are not very keen to go ahead with this sort of dermal patches. But one of my senior colleagues from UK, Dr. Modi, he has done a very large series of graph jacket, and he keeps coming to India, and he has presented his work, and the results are very promising. He has done more than 200 cases.
Wow.
Where the results are good with long-term follow-up. So, but I think with newer options available slowly and the cost constraint, I think still it has not picked up so much in India. So no great experience with that.
Yeah, me too. Sanjay, any thoughts?
I concur with the Shirish. In India, we haven't got any graph jackets. My exposure since year 2009, when I visited USA in prominent Dr. Buckhead, and he was using this PRP into the, to augment the healing in the repair in 2009, and this is 2020. Still on PRP front also, we have no conclusive evidence that whether it works or not, whether it works significantly, what kind of work, what combination, and they're all theories. It is a work in the right direction, but it has not reached to a point where we can conclusively come to an agreement. So all this, current evolution in the healing augmentation is going in right direction, but it's not yet there. That is my feeling right now.
Okay, Dr. Yudeo, do you want to comment something about that?
Yes. I understand that these patches, they do as a conduction aspect. And we have to increase biologically, injecting the PRP or now doing the acromioplasty. So here we have a Switzerland a patch, which costs $2,000. It's a 4 + 4 centimeters. So it's very expensive. And we are not allowed here in our state, in Brazil, in Minas Gerais, to do the PRP at the moment, because we had so many commercial issues involving it that it's prohibited at the moment. So now we have to wait a little bit more to do this kind of procedures, unfortunately.
Okay, good. So another thing that is coming, and I think that, well, that's something that I was thinking about. I have I would say, an interesting question to Shirish, which is, he was talking about the micro fractures and the idea of Crimson Duvet talking about Steven Snyder. But I was thinking about something. I already do some micro fractures or perforations when we put some anchors. We know that. And we don't have much bleeding because the anchor is in place, but there is still some blood coming. But my question, I think it's a very interesting one. How much would you be afraid of having a greater tuberosity fracture doing micro fractures and the other perforations when putting anchors?
See, so when I do microfracture, my idea is, first step, what I would do is I will check the osteoporosis. I would put the trocar and check how strong is the bone. Okay. If I find it's quite osteoporotic, my typical sequence is I would never take away the cortical bone at the junction of the cartilage, because there is the area where I want to put in my anchors. I would prefer anchors which are open architectural type, which will allow a lot of bone marrow to come out and bone ingrowth as well. So fenestrated anchors. And whenever I do microfracture, the lateral half of the footprint, there I concentrate primarily, and I make sure that I don't go too deep. I would make perforation about 5 millimeter at a distance from each other, and I won't go beyond 5 millimeter deep. And I would avoid areas closer to the anchor, because I don't want to make the anchor weak by compromising the bone around the anchor.
You don't have a pull out of the anchor, of course.
Yes, absolutely. And
Yeah.
if I find bone is too weak, then just the tuberoplasty is good enough. It is going to open a lot of channels.
Okay, and which instrument do you use to do the microfracture? Because I couldn't understand.
No, the same trocar with which I make a hole for 5.5 anchor, the tip of that same instrument, I use it to create a microfracture.
How, and what is the biggest number you would do? 2 or 1 or 3? I would be afraid of doing more than 1 and to create a fragility situation on greater tuberosity and having a fracture. Because see, an intraoperative fracture of greater tuberosity would be a very complicated issue. I never had it, and I pray that I never have it in future. But having said that, how many perforations? Let's see that you are, putting
3 to 4.
Huh?
3 to 4.
Okay. I guess that Dr. Ildeu, you were raising your hand to say something about it. Yeah, okay.
Yeah, I have a comment and a question for Dr. Pathak. I like to do the perforations. I use the perforator of 1.5 millimeters that we use for small anchors for instability. And we perform one perforation okay, and sometimes we do not need to use the hammer because the tuberosity is so soft, so you just perforate it by hand. And I have a question about how much do you debride the greater tuberosity? Because I found a paper telling that we do not have to remove everything, all the reminiscence of the tendon, because some parts of the tendon might induce the healing process, stimulate the healing process, or the indifferentiated cells to tendon cells. And saying that the biological issue, I would like Dr. Pathak to say if there is any point of, this is a true, that if you keep some part of the tendons, parts of it around the tuberosity, if it increases the biology or not. Do you believe that we have to remove everything and perforate the tuberosity?
No, most of the times I try to do a double row transosseous repair equivalent. And in those cases, I try to clear off all soft tissues from the footprint and do extensive tuberoplasty, I would say, in the lateral part, make perforations and do a double row repair. So I don't rely on the tendon tissue, but I would take a close look because that is going to tell me the tendon loss, but I don't try to preserve them. But yes, the anterior and posterior cable, I would definitely incorporate when I do the repair.
I just want to make a comment. I think that everybody should listen to it carefully because I've been thinking about it too much. The most beautiful paper I saw, the most beautiful lecture I saw in International Congress last year was from a Japanese guy, because he divided some patients in 3 scenarios. The first one, a full tuberoplasty with a bony bed. The second one, he didn't do nothing, and he left the remaining tendon and the cartilage, not only the tendon. And the other one, he made a small debridement, and after it was in and after 1 year, something like that, he came back, he picked a small piece of the tendon, and he sent this to histology. A beautiful paper, a lot of difficult to do this, but in Japan, I guess, the patient accepted to do a second look only for, I would say, scientific reasons. And when he did the histological analysis, the quality of the scar was better in the cases in which he left some cartilage and some tendon in the insertion. So that would maybe change our minds not to do a full tuberoplasty, but to left some cartilage over there together with some tendon. So that would be a new idea, and I have been thinking about it. It's new, and there was a guy from Chicago saying that considering this idea, he would do in the greater tuberosity, a healing zone and a fixation zone. So in some part, he would leave the tendon, and in the other one, he would see the whole bone to have a better idea of the purchase of the anchor. This is something very new. I guess that Dr. Ildeu was thinking about it, but you see, this Japanese idea is, I'm really thinking about it. How much do I shall leave the native tendon of this insertion, and how much do I must care about it to leave some cartilage over there, to leave some tendon, or to take it all? Because the old idea is to take it all, as Shirish was telling us. But have you been changing your mind, Ildeu, about this? Because I have the sensation you are changing your mind. I'm trying to change, but I have the doubts, and that Japanese paper, but no more papers I have seen. What can you clarify something about it, Dr. Ildeu? And if someone wants to talk, I think that this is very interesting to discuss.
I have changed a little bit the way of doing the cleaning the tuberosity, because in the past I used the soft tissue shaver first, and then I used a little bit of the bone shaver, and now I just use the soft tissue ones. And if doing that, some tendons, part of the tendon remains attached to the tuberosity, but just a small part of it, because I like to have a contact between the tendon and the bone. That's it.
Okay, Sanjay wants to talk about it, huh?
My two penny worth is this, that if it is a young patient post-traumatic care where there is a stump at the tuberosity, I would leave it there and do a single row repair with through the tendon remnants, microfracture, and just leave that everything to just gel on its own. But otherwise, in a degenerative kind of situation where there is hypovascularity at the, this watershed area of the degenerated cuff tear, I would need a good, biology coming from the greater tuberosity, and hence I would not really leave anything there. I haven't come across that paper which you are talking about, Sergio.
Okay.
Make an interesting read.
No, it's very nice. But the thing is that you are trusting, as we have trusted for years, in a word which is blood. You trust in, But the thing is that maybe it's not only blood, but the remaining stump plays a bigger role that we were thinking about. This is something that we really should think about. But just changing a little, because I want to give attention to the audience. Someone is asking. I have absolutely no response. If you, I guess Dr. Ildeu has more experience about it. If you do some laser and ultrasound in the beginning of the physiotherapy, do you think that these devices of these tools can increase the biology of the tendon? I have absolutely no idea, but coming is question from the audience. the question.
Well, we are talking about resources to increase healing process, mechanical or thermal or biological. So if we have a good young guy, I think we don't need that because the biological response is very good. We are going to have the inflammatory phase, okay? And we are going to have the healing process done without problems. But if we have a chronic tear, old guy, I think we can use some of these resources like ultrasound or laser to increase the inflammatory response, because these patients sometimes they do not have this big response. So that's I don't have a paper or to confirm. This is something I feel based on my experience.
Sanjay, any thoughts?
For the bone healing, ultrasonic waves has been tried, but for tendon healing, I don't think anything other than blood, which is inside at the repair site, works.
Yeah, Shirish.
No, not for healing, but sometimes certain patients have too much of pain. So we use TENS, transcutaneous electrical stimulation, to relieve pain and to avoid high dosage of anti-inflammatories.
Okay, because Dr. Ildeu was talking about something very interesting, because this is something that I face. I think that we can discuss this. The thing is, Burkhardt says that in big tears, you will have much less pain than in small tears post-operatively. The problem is that, especially in women with small tears, I've been having a lot of cases of post-operative stiffness. And the thing is, as Ildeu has said, stiffness I can manage. Failure, I cannot manage. But the problem is that I had some cases last year about CRPS, complex regional pain syndrome, reflex sympathetic dystrophy, which they give me a lot of work. So I know how to manage that because I do a lot of fractures, and then I have to enter with gabapentin, pregabalin, C vitamin B complexes, and it gives me a lot of difficulty. So the thing is, how do you manage to avoid stiffness? It's a difficult question, and CRPS, which is a bad issue. I know how to manage, but when it comes, it's a mess.
Okay, Sergio. In my experience, I am not doing partial thickness tear for young ladies anymore, repair for young ladies, because I had the same situation of frozen shoulder after these repairs, because I think that the biological response is too high, and these patients sometimes they go very well doing a conservative management, conservative treatment. So saying that, I try to identify the risk factors for a frozen shoulder before the surgery. And if I have a lady, 50s or 55 years old, very anxious, very diabetic patient, patients with metabolic problems of thyroid or other problems, and patients that needs medication, central medications for sleeping, and these patients, they are more tendent to have frozen shoulder after surgery. So in these cases, I talk to the patient and I try to use some painkillers before the operation, 2 days before the operation. It's like a preemptive analgesia. So after the operation, I try to do a multimodal protocol using not only anti-inflammatory drugs, non-steroid anti-inflammatory drugs for 5 days not more than that, not to interfere in the healing process. And I use some different kind of drugs as well, like you told us that you use for treating the complication. So I think that when I start seeing that the patient is having too much pain after the surgery, I have no problem doing a suprascapular nerve block straight away. So that's the way I try, and I stop doing the rehabilitation regarding movement, because I keep the patient comfort in the sling, and the protocol for rehabilitation is just for pain in the beginning. So I just start moving the arm after having the pain controlled.
This is very important, and my experience with suprascapular nerve blocks is very big. I'm very happy with that. 13 years doing that. Dr. Eudeu seems to do it also. It's very good for frozen shoulder. I know it's a big discussion, and for CRPS, reflex sympathetic dystrophy. But how do you, what your experience, Dr. Sanjay and Shirish, on dealing with pain in stiffness and CRPS? Do you have it, yes or no? And what do you think about suprascapular nerve blocks? The thing is, Doctor, this is a very nice discussion. We have something like more 30 minutes to discuss, as long as we wish. I would like to keep here all day because it's a lot of things. But the thing is, we still have 30 minutes. So I think this is very important, because it's not the success, as we have discussed it, is not what I do intraoperatively. It's what I do preoperatively, intraoperative, and post-operatively. So it's not only about how to conduct a post-op rehabilitation, but in identifying post-op problems and how to manage that. You all know that I am absolutely in the right way of thinking. So please, Shirish and then Sanjay, your experience with complex regional pain, how do you manage that? Medications, suprascapular nerve blocks. I think this is a very productive discussion, please.
Yeah, so Sergio, you mean it's a post-op case with ISD, right?
Yes.
So I think, first of all, while selecting patients for repair, I would be very selective if someone who has a partial articular tear, a diabetic, hypothyroid patient, and very apprehensive about the result. I would prefer to avoid this kind of patient, because I know this sort of patient would give a lot of trouble in post-operative period. If at all, if we decide, then I would always go ahead with a down in a partial rotator cuff tears. I would not do a transtendinous repair. So I'm more comfortable taking a complete the tear and do a proper repair, because the part of the tendon which is still macroscopically intact, it has been shown in literature that histologically it is abnormal. So better to get rid of that tissue. In those patients, I would be, as I said, individualized post-op rehab protocol. I would be a little aggressive in early post-op period. I would start early passive range of movement, early pendular hangs, most importantly, external rotation exercise. I would start from day one. Third, yes, I use suprascapular nerve blocks and transdermal patches in such patient. Pregabalin, gabapentin, they of a great help in treating them. And you have to counsel them that this is going to be all right, and it is going to take at least 6 to 8 months. That's what I tell them on day one. And so in few of my patients, I have taken help of my colleague who is a pain specialist, and we have done some stellate ganglion blockades and everything. And I think you have to just buy time, 4-6 months. By the time, the natural history also cures the.
Sure. And another thing that I'm very serious, Dr. Eudeu, I want you to comment, Sanjay. You see, this kind of patient, especially young, middle-aged ladies, it happens a little bit more. There is literature about it, but I think I'm very serious. that you must spend time talking to them, talk. You must give her emotional attention, because these kind of patients, they need more psycho-emotional attention. It's difficult to find literature about it. It's very easy to see in the office. So it's medication and emotional support. I'm very serious. I don't know if you have these patients in India. I have a lot. And
yes,
yes, I'm gonna be very serious. I think that in that age, these ladies, they have problems, because I'm very serious. The kids, they are leaving home, so the motherhood is not so strong to feel her emotions every day. And then you see, sometimes I'm very serious, the marriage is a little bit wasted. All of these things, they play a role. And I make some jokes with my residents. When they get older, they have grandkids, and then the mind gets better, because they can feel their emotions in a different way. I'm very serious, because I see this. When they have grandkids, it goes better. Okay, it's a personal 15-year perception, but I talk a lot with them to give them emotional support. I think this is very important in this kind of patient, in this kind of post-op. Dr. Ildeo, do you have any concerns about giving them, I would say, some emotional comfort? I'm very serious about this. I'm serious. What do you think about it, and Sanjay, in this specific kind of patient?
Should I go?
Yes. Please.
No,
Please.
you can go, Sanjay.
Okay. So, Sergio, these are very difficult cases which you are talking about. So during the clinics, I tend to keep my radar really up for this, and I try to conserve them as far as possible, but once a year I get caught in this. So when this is a PASTA or partial articular cuff tear, and I take the challenge to make them little happier, counseling. So that is very important. And then during the surgery, I take care of bursa more aggressively. Wherever I see red, I just go and clear it out. I release their capsule proactively, so that whatever effect of the secondary stiffness is there, I get ahead of that. Then I use interscalene block with, if possible, with a catheter, so that for a couple of days, that patient is pain-free. And then I use this opioid patches, pentagocin patches. And along with that, I add a little bit of antidepressant, and then, keep them very close. You call them frequently for follow-up and give them enough time. They chew your brain, but in the end, say at the end of 6 to 7 months,
they are better.
They are better. And one thing I do at the beginning, I charge them double.
That's very good. That's fantastic. I'm very happy to know that all of these 50, 60-year-old ladies with emotional weakness, I would say, they are not only in Brazil, they happen in India. I'm very happy about it. Shirish, any concerns about this, I would say, these middle-aged ladies, which this emotional, allow me to use the word, not weakness, but characteristic. Do you pay more attention to them post-operatively? I love it, the expression Sanjay used it, they chew your brain. So they chew my brain too, and they chew my heart, because they are emotionally demanding. So how do you manage that, Shirish, on I would say, on a regular practice? Because I want to know that you suffer as much as I do.
I should confess, now I'm practicing for last 12 years, but still this sort of patient, when they come to my outpatient, still they give palpitations, because that next 20-25 minutes are gone. and you have to keep talking to them. But I think it's very important. I always call their close relatives, especially if she's an elderly lady, I would call her daughter-in-law. And you have to make sure that daughter-in-law understands that she is not a malingerer. It's a real problem. She's suffering because from outside they feel that she's just making some fuss. So I make sure that every family member understands this is a problem, and together we have to find a solution. And I think this few detailed counseling sessions are good enough. And you have to just make sure that they don't feel that you are trying to avoid them. Rather, I tell them that either you come early in my outpatient hours or you come last so that I can give you more time. So I think a couple of sessions, and if you convince them that you're going to get all right, they are okay.
Okay. Yeah, okay. Sometimes my physical therapists, they make a joke that these ladies, they don't need so much physiotherapy, but they need psychotherapy. So it's another way of seeing this. But there is a nice question coming. There is a wonderful shoulder surgeon in the state where Dr. Ildeu lives, Minas Gerais, Dr. Mota, José da Mota. He lives in a city called Juiz de Fora. He's a very good friend of mine, outstanding surgeon. And he's asking me a question here in WhatsApp because he deals a lot with athletes, and I don't deal with athletes. It's very uncommon. He's asking me if you think differently when you are dealing with PESTA lesions in athletes and not in ordinary patients. You see, I have a way of thinking of PESTA for non-athletes. My experience with athletes is very small. Dr. Mota, he has a big experience, and I would like you to know, do you think differently to deal with PESTA lesions in high demanding patients from an athletic point of practice? Would like us to talk about it, please. Dr. Ildeu, can you start?
Well, based on the papers, I can say that I like to perform, to complete the lesion, to have a 100% repair in these cases, because the biological aspect of the healing process is stronger when compared when you do a partial repair. That's the way I like to do it. I don't have too many experience to athletes, but regarding these partial articular tears, I feel more confident doing a 100% repair because I can control the tension and I can control the exact part where I'm going to reinsert the tendon. That's my experience.
Okay, so my feeling is the same because Burkhardt says that in partial tears, you must take all of the bad tissue from, I would say, a macroscopical point of view. But what Ildeu has said is absolutely as my feelings, that the biological potential in this patient is very high because they, I would say, they are younger, and then they have good biology. And the thing is, so I really think like that. But what is your experience, Ildeu, and then the others with athletes? Because mine is so small. What is your experience and acting like that intraoperatively? How do you see them 6 months, 8 months, 1 year after surgery in sports activity? Do they really get better?
The question is that these shoulders, they are not young anymore, because these guys, they have a high demanding activity. So
That's
sometimes in a patient of 25 or 30 years old, we have a 60 or 70 years old shoulder. So they have to understand the limits of it. So I talk too much about them, about the limits of the treatment and how can we improve biologically, and the protocols of post-operative are a little bit different because they have different phases to to cover, because depending on the sports that they are involved, like tennis, like volleyball, like soccer, we need to do some specific post-operative protocols to put these guys at the same level that before surgery. So it's not easy. And sometimes you have to do more than one operation in these guys. That's the problem.
Okay, and then I'm gonna do a very interesting question. When you have a 30-year-old boy with a serious pasta tear that needs surgery, you know that the problem is not exactly impingement, but intrinsic tendon degeneration, okay? Having said that, would you still do an acromioplasty, even a smooth, just to have some bleeding upon the repair? I guess you will say yes, but it's still a nice question.
I think in this case, sometimes you can do injection into the tendon, into that intrasubstance of the tendon, because doing just an acromioplasty, probably the cells are not going to achieve the part of the tendon which is degenerated. So I like to open a little bit longitudinally the tendon and to create a path to use the shaver and debride it a little bit. And in this way, after that, I do a suture over the top to close the tendon. That's the way I do it.
Okay, Sanjay, your experience with pasta lesions in athletes to Dr. Mota, who is very interested in this topic, and Shirish, because my experience is very small.
So my experience is also very small, but in athletes, in younger athletes, I tend to really, treat them conservatively. And when I operate, I do completion of tear, repair, good vasectomy and rehab, early mobilization. And I need to tell them that your post-operative level in the performance is not going to be, improved or amazing. You will have to understand that it's up to him. I just shift onus to him to use this surgery as his advantage and bring best out of him and adapt to this new tissue and re-educate and then perform. That is my strategy. But very small volume where in a my style of practice in these cases.
Shirish.
You are muted.
Oh, no.
I have treated a few of them. So I think when you are dealing a overhead throwing athlete, it's a thrower shoulder. So we can't just look at the pasta lesion alone. I would make sure that all components are well taken care of, looking at the scapular dyskinesia, the internal rotation deficit. I would put them on a good supervised program where we would stretch out his posterior capsule, put them on good scapular rehab, strengthening program, sports specific training, and most of them, they get better. Now I would divide these athletes into two groups. One who is still continuing to play at whatever level, state level or national level. I am very reluctant to touch them because the return to sports after surgery in the worldwide literature, the percent is very less. But someone who has played for a lot of years and now he's out of the game, out of the team because of this injury, then these are the patients where after an adequate rehab trial, if they are not getting better, then I would counsel them that yes, we can try our best, but I'm not sure. But at least you should be able to get back to sport. May not be at the same level, but you should be there. And then with a well-informed consent, we try our best. And few of our patients, they still manage to get back to the same level what was their pre-injury. But still the chances of having recurrent pain and getting back to the clinic is very high.
No, and so what you're saying, and it's very clear for you, me, and all of the panelists, but I'm talking to the audience. We must be very honest with these patients in a way that, see, I'm gonna try my best, but I cannot promise you that you will come back, or you will come back, I would say, recreatively, but not in a competitive level. And you see, the problem is that you are getting old. It's not me, the surgeon. You are getting old, and this is very important. But the thing is, we have to pay a lot of attention in scapular dyskinesia, because this is important in everybody, especially in athletes, because they are high demanding. But there is then one thing that I want to question, because it's very difficult to me, and I want to see if you suffer as I do. The thing is, I pay a lot of attention in scapular dyskinesia post-operatively. It's very important, especially if I am acting with recreative, middle-aged sport people in the gym. These cases I can handle well. The problem is that in old patients, especially in obese ladies, and they have spine kyphosis, in English is kyphosis, it's very difficult to work with the scapulas, even if you operate the shoulders. They are the cuffs, they are low demanding patients. But I have a lot of difficulty in, I would say, treating scapular dyskinesias in old patients, especially in obese ladies with kyphosis. Do you have the same difficulties? And how do you try to improve it post-operatively after a cuff repair? I think this is a difficult question, but a practical one. Dr. Hilde, how do you suffer? Do you suffer too?
Well, I think we have to pay attention about the origin of the pain in these cases, because some of these ladies, they have pain on the AC joints because of the position of the scapula regarding the rest of the body. So the protraction of the scapula increases the pressure over the AC joint and the sternoclavicular joint as well. So some of these ladies, they have what we call how can I say it in English? It's the pec minor over tension. Okay, it's a syndrome.
No, just a second, and you will continue now. Is the pec minor overtension leading to myofascial pain? This is what you want to mention, myofascial pain.
Yes.
Yeah.
So I think the key point in this case is to perform a proper strengthening of the scapular muscles and stretching the pec minor and pec major muscles, and sometimes even the subscapularis. So it's difficult because these ladies, they are lazy and they don't like to do some exercises daily. So simply they do not do the treatment properly. So in this case, it's difficult. And we sometimes we indicate the surgery trying to compensate conservative treatment that was not done in a proper way, and trying to do using surgery. And this is not a good thing to do, because they are going to complicate. I think this we have to try to treat conservative as much as we can.
Yes, and as Sanjay has said, and after surgery, if they are not fully okay, they are gonna chew your brain. I love the expression, Sanjay, okay, because they chew my but I say my brain and my heart. But still, Sanjay, about scapular, the scapular part of rehabilitation, old ladies, obese, when you operate the cuffs, they are low demanding. I have so much difficulty to work this part physiotherapically in post-op scenario. Your thoughts about it? How do you deal with that?
So the one thing is that I commence this exercises before the surgery, the scapular stabilization exercises. So they are familiar with these exercises once I operate. And as soon as, they are out of anesthesia and they're comfortable, say 4 or 5 hours after the surgery, they start at least scapular bracing exercises. And I put them on those table slides and, just elbow exercises. And then in the next phase, when I mobilize them passively to control the scapula, I ask them at home, the supine exercises, they lie down and their scapula are touching the bed, and then they do passive exercises. And that educates that scapula and their muscles to really, act rhythmically. So to avoid this sitting position, shrugging or what you call trick movements, I want them to do passive exercises in initial 6 to 8 weeks if it's a big tear in a lying down position. That is my trick.
Okay, we are finishing just in a second, but Shirish, do you want to make final comments? Because you didn't answer. I just want to hear your thoughts and then we will finish. Shirish,
So,
any thoughts about this?
Yeah, so I think you have to make patient aware about the scapular issues, and we have a good shoulder rehab team. So where we advised post-operatively few supervised sessions, and we sort of tell patient that surgery is only 50%. 50% is a proper rehabilitation, and if you do it, then only you'll get the good result. And I think most of the patients follow that rehab protocols, and we have very good results with supervised rehab protocol in early post-op period. And then sequentially they keep coming 2 weeks, eventually 4 weeks later for follow-up visit with physiotherapy. And we make it sure that we work on the scapula very well right from day one.
Okay. So see, my friends, it was a lovely discussion, but we have to finish because Dr. Ashok has a lot of webinars to run. Before my final statements, Dr. Ildeo, do you want to make any final comments? Sanjay, yeah, we have 1 or 2 minutes for everyone to speak if you wish, of course. Dr. Ildeo, any final statements? Feel free, my friend.
Thanks, Sergio. First of all, I would like to thank Ortho TV. I would like to thank Shoulder Planets. That's my mug here. And lots of Brazilian guys, they are asking for one, okay? Please be aware of it.
Yeah,
and,
thank
We
you.
also want one.
Oh, yes, I'm going to send you, I promise. Yeah.
And I'm really happy and honored to be part of this discussion. And thanks for the opportunity. And Sergio, you have done a lot of Brazilian shoulder surgery. And I would like to congratulate you and your relationship between India and Brazil. You have established a channel of communication, and this is very important for both countries. So congratulations for all of you. Thank you.
Okay, thank you very much. I am very happy about it. Sanjay, if you want to say something, the microphone is yours.
Right, Sergio, it is my privilege to interact like this freely without constraint of time, speaking our mind and heart-to-heart discussion on this Ortho TV facilitated webinar on your Shoulder Planet platform. Thank you very much for making me part of it. And
yes,
I thank my fellow participants for their participation and listening to me very patiently. Thank
you. Shirish, do you want to say something to finish?
Thank you, Ashok. Thank you, Neeraj. Thank you, Sergio, Sanjay, and Dr. Ido. Thank you very much. It was a fantastic academic feast.
Okay, so see, this to be very honest, this one of the most beautiful moments of all of my Indian, I would say, endeavor that started 10 years ago. I'm very thankful, like my Indian friends do. They do like this. So
Namaste.
Thank you a lot. Dr. Ashok, it's a pleasure to be here. I thank you too much, Ortho TV, the formal and very brotherhood that we are establishing. I hope that we can continue these projects, and I'm very happy that in a very spontaneous way, Dr. Ashok, he mentioned this as an Indo-Brazil event, because this is not my event. This is an Indo-Brazil event. I think we have to join forces to be stronger together, to use internet. I'm very happy about it. And as long as we can, I hope we can do in future more events like this, connecting Brazil with not only with India, but with people from other countries. I think that this is the spirit. I'm very happy about it. Dr. Ashok, if you want to say something to finish it, I'm going to be delighted, my good friend.
Sure. I think it was a really great event. We were joined by around, I think 900 to 1,000 people joined us online and watched the thing. The discussion was very lively, and a lot of things about the biology of RCT and how the repair heals. A lot of concepts were clear, especially with the discussion amongst the panelists. So it was a really good webinar and added a lot of academic value to the viewers. And like you said, it's an Indo-Brazilian venture, and we should look ahead in doing this regularly as much as possible for both of us, and we involve more people into it so that we can share knowledge across continents and across the world. So
okay, just a final statement that I am very proud to say that if we can do another one, I am delighted. And just for people to know that I have invited one of the most important persons nowadays of the world shoulder scenario, which is our good friend, Dr. Osvandré Lech, which is not only a good friend of Dr. Ildeu and of me. Dr. Ildeu helped me in the invitation. I thank publicly Dr. Ildeu to invite Dr. Osvandré Lech, who was not only ex-president of Brazilian Orthopedic Society, but Brazilian Shoulder and Elbow Society, and he's now the president of International Board of Shoulder and Elbow Society. He's a very important guy, very proactive, very clever man, very intelligent. And he has already accepted the invitation as long as we can do a second event. So I am super proud of saying that. And we have other guys to invite of very important people from, I would say, abroad. I don't have the yes, but we are trying. Dr. Ildeu is giving me super support on that. So the thing is, I just want this to be the start of a new, I would say, digital relation between Brazil and India. I'm very proud of that and very happy. And I hope to see you guys soon, as long as we can, of course, in a second event. Yeah. As long as Ortho TV give us the opportunity, I guess we will have. And the biggest responsible for all of this journey is Dr. Ashok, Dr. Neeraj. They are extremely active, and thank you from the bottom of my heart, my good friends.
I think Neeraj coordinated all of them, and he can end the meeting with his final words. Neeraj. Go ahead, Neeraj.
Okay. Yeah. So we will definitely do it on a regular basis. We will coordinate again. We will keep that group on so that it will be very easy for us to coordinate. So with this, we end our meeting. We end our first Indo-Brazilian shoulder meeting today. Thank you very much, and bye-bye.